Good afternoon, everyone. As I mentioned this morning on the panel, I've got this, I guess unique is one way to describe it, position where as a researcher I think about value from the perspective of society, but as a clinician, as an oncologist, I have to think about what the patient in front of me wants, right? So not patients in general, but the patient in front of me. And I can tell you that, and for those of you who are clinicians, you know exactly what I'm talking about. It's challenging. Let's start with this question. So 50% of Medicare beneficiaries spend what percent on out-of-pocket costs? %30. So the answer was actually 10%, and I'll talk about that in a minute here. So in terms of my disclosures, I think this is important to note. Again, I spent a lot of time talking about the cost of care and the expensive pharmaceuticals that we prescribe, but my wife works for Novartis, so I am quite literally married to the pharmaceutical industry, which makes for an interesting potential conflict of interest. So when we talk about value, we talk about value from the broad perspective. It's quality over cost, right? I think we all understand that. But when I'm talking about value to the patient in front of me, right? Patients don't think in equations. I don't think in equations. And what that patient wants to know is how much is the care that I'm going to prescribe to them going to meet these measures. And I would say the vast majority of patients that I talk to, cure is what they value the most. They value quantity of life, they value quality of life, and somewhere in there, maybe, if I ask, cost comes up. Now, that it only comes up if I ask. It doesn't mean that it's not there as an important part of what they value, but many times, and particularly the first time that patients meet me as an oncologist, they don't want cost on the list. And the question is, at what point does it become a part of the decision making, and when does it become important? So when we're talking about cost and benefit, when we're talking about value in cancer care, there's a lot of different ways to approach it. But we've heard a lot today already about the rising cost of care. And again, as we mentioned this morning on the panel, I'm not sure those costs are necessarily in line with the amount of benefits that we're seeing. So this was an interesting study that was published in JAMA Oncology earlier this year, where the investigators looked at 51 drugs with an oncology label and looked at the price of those drugs, as you see on the y-axis, compared to the improvement over standard of care, as you see on the x-axis. So that's improvement for each drug compared to its phase 3 randomized standard. And that's in percent change. And what the investigators found was that there was very little correlation between the price of the drug and its actual improvement over standard of care. For example, this drug here, which is the most expensive drug on this list, only had a 20% improvement in overall survival compared to its standard comparator. So that led the investigators of this study to conclude that current pricing models are not rational, but simply reflect what the market will bear. And so, when we talk to patients and get an understanding of how much patients are paying for this care that doesn't necessarily reflect its value, that gets complicated because patients are actually paying quite a bit out of pocket despite having insurance. So I think most of you answered that when you're talking about Medicare beneficiaries with cancer, 50%, you said, spend more than 30% out of pocket. So actually 10% is the threshold that is typically deemed to be underinsured. So if a patient is spending only 10% out of pocket, that means they have poor quality insurance. What that means is that every other Medicare patient that I see is underinsured. 28% of Medicare beneficiaries spend more than a fifth of their income out of pocket on cancer treatment related costs. And then what becomes more interesting is what patients are willing to do for their cancer care and how much they're willing to pay. So we've done some studies that I'll talk about in a bit that describe how much patients have paid and the sacrifices they've made for their cancer treatment. We did another study recently where we asked patients, what would you be willing to do? How much would you be willing to sacrifice for your cancer care? Half were willing to declare a bankruptcy. 39% were willing to sell their home, and nearly 3/4 were willing to spend less on food and clothing. Interestingly, we did not phrase the question to ask patients, what would you be willing to do for curative cancer care, or even the best cancer care? We just said, for any cancer care. And despite that, patients were willing to make these sort of sacrifices. So I'm sorry, I think based on the transfer and templates, this is not quite showing up well, but the reason that patients are paying so much out of pocket and realize now more than ever that they have to make these sacrifices, these financial sacrifices, has to do That's okay, I've got a really loud voice. Is that back on? Okay. Has to do with the price of drugs, but also has to do with cost sharing and the growing financial burden that patients are asked to carry on the part of payers as well. And one of the best examples of that is the price of premiums. And what we've seen is that insurance itself has become more expensive. So here you see inflation from 1999 to 2013, with worker earnings having kept up with inflation. Premiums have gone up by 182%, but worker contribution to premiums have gone up by nearly 200%. So we're already paying more for insurance even before paying for the cost of catastrophic illness care. Deductibles have nearly doubled over the past 7 years. And we're seeing more and more of these high deductible plans. And what's interesting is that a recent study found that about 50% of Americans don't have enough cash on hand to meet the deductibles for these high deductible plans. So already, our patients are entering into the health system unprepared and unable to afford their care, even if they have insurance. Importantly for my patients, we're seeing more multi-tiered formularies, which is another form of cost sharing. And I think all of you understand what a multi-tiered formulary is. And specifically for my patients, the oral chemotherapy drugs that I prescribe, a lot of the expensive supportive care medications I prescribe fall into these higher tiers. And as the last time I checked, on average across the country, in tier 4 and 5, the average copay is about $80 a month. So what happens when patients incur high out-of-pocket costs? You would think, well, it's just it's a cancer diagnosis. If it's a few $1,000s out of pocket, you'll pay it and sort of deal with it. But unfortunately, the situation is much more dire than that. And in fact, there was an interesting study a couple of years ago that showed that just having a cancer diagnosis was associated with a 2.65 times higher risk of declaring personal bankruptcy. So let me say that again. Having cancer more than doubles your risk of declaring personal bankruptcy. This was a really interesting, groundbreaking study. But this year at ASCO, the investigators took the study a step further and asked, so what? So what happens when you declare bankruptcy? And they took all cancer patients in this study and matched those who declared bankruptcy versus those who did not. And what they found that in over 7,000 matched patients, those who declared bankruptcy had a 79% greater mortality risk. So, having cancer increases your risk for extreme financial distress, in this case bankruptcy. And declaring bankruptcy, or experiencing extreme financial distress, significantly increases your risk of dying from it. Well, why is that? Well, that's the important question, right? Why does extreme financial distress increase your risk of mortality? So I think there's a few reasons why, and that's where a lot of my research has focused over the past few years. And the first is the impact on patient well-being. So the first study we did a few years ago looked at this question of the relationship between financial toxicity, and this was the study that sort of coined the term in the literature, and well-being. We found patients who had insurance and had a cancer diagnosis were mostly willing to forego vacations. They were cutting back on groceries and clothing, and they were spending their retirement savings to help pay for their cancer care. So clearly, well-being and financial well-being is impacted. But what about quality of life? And I think this is another mediating factor between extreme financial distress and greater risk of mortality. So there have been a couple of studies now. We did a study recently where we found that patients and survivors who had high financial burden were more likely to report poor quality of life. And again, these are patients who are actively undergoing treatment and patients who are no longer undergoing treatment or survivors. So here we're talking about patients who are experiencing financial burden and poor quality of life as a result of it or associated with it, even though they are no longer receiving cancer treatment. But I think the factor that is most important and best explains this relationship between high financial distress and greater risk of mortality is quality of care. And quality of care is defined by adherence. So there have been a lot of studies that have looked at the relationship between out-of-pocket costs, copays, and adherence to anti-cancer therapy. The one that I found most interesting looked at adherence to imatinib, so Gleevec, in patients who have chronic leukemia. And this study found that in patients who had started the drug and were within 6 months of starting the drug, patients who had a higher copay were 70% more likely to be non-adherent to this potentially life-prolonging drug. So what's interesting about this study is what that threshold was for higher copay, right? They looked at higher versus lower copay. And in this study, it was about $53 a month. So not thousands or hundreds of dollars a month, but about $50 a month. And keep in mind what I said earlier, the average copay for drugs that are in that fourth tier, again, most of the oral chemotherapy drugs that I prescribe, is about $80 a month. And I think this just goes to show how sensitive our patients and their budgets are to small changes as a result of cancer treatment. We did a study where we found that among insured cancer patients, 45% self-reported non-adherence. So in this case, self-report of non-adherence was defined as not taking their prescribed meds, taking less than their prescribed meds, or taking somebody else's medications, all to save money. So when we think about this relationship between extreme financial distress and greater risk of mortality, there are at least these reasons, these mediating factors that might explain it, and probably others that I haven't thought about or I haven't discussed today. But what we have now is a growing list of evidence-based financial toxicities of cancer treatment due to the cost of cancer care. And based on that, we have to ask, how can we intervene? And keeping all of these in mind, how do we define value for patients? How do we help patients make decisions, knowing that the treatment that I'm going to prescribe to them, which I think they should get, because I think it's the best treatment for them, might cause some or all of these financial side effects. So, I think we've got a few tools that might help integrate effectiveness of treatment, toxicity of treatment, and cost. And I'm going to talk about some of them, and you've heard about many of them already, so I won't belabor the point. But the first is, of course, ASCO's value framework. So here you see, data from the paper that introduced the value framework. And you see two regimens for lung cancer compared by clinical benefit, toxicity, and that combined net health benefit score with cost adjacent to that score, not combined into it, right? So here's another way of looking at it. When you combine these two regimens, the regimen with bevacizumab has a net health benefit score of 16. You see the drug acquisition cost, and you see patient copay, which is calculated per patient. And of course, the results are presented, in paper form here. So I think one of the benefits of this ASCIO value framework is that it actually does help patients better understand benefit compared to toxicity. I mean, that's something that we don't do very well in practice. I don't think we do a good job of explaining to patients what the benefit of their treatment is or what their potential side effects are. Now, cost is listed here next to the net health benefit score, not a part of it. I think one of the downsides of the ASCO value framework is that cost is presented in terms of drug acquisition, but to determine how much the patient is going to pay for that actual regimen is very difficult, and this tool doesn't actually help us do that. Another one that we've heard talked about today is the NCCN effectiveness blocks. And basically, for this value tool, efficacy, safety is measured. What's different to ASCO is that the quality of evidence and consistency of evidence is also included, and this is, fairly consistent with what NCCN has been doing in terms of their recommendations to place a category, a level of evidence with all of their recommendations, and then affordability. As with the higher score for each of these, the blocks are filled in. And so this is what it looks like in their CML recommendations, where, for example, for primary treatment for chronic leukemia, your options are imatinib, nilotinib, or dasatinib, and you can see how each of these blocks are colored. So if I'm going to NCCN to figure out how to treat a patient, not only am I going to get the treatment recommendations, but I'm going to see those colored in blocks as well. So again, the upside of this tool is that we can actually compare side by side what my options are. The downside again is that there is no sort of synthesis of the score. Each one of these categories are left there for me to interpret. So I can either say, well, cost is most important to me, so I'm only going to go by that, or look at effectiveness, but there's no combined score here. And then, this morning we talked about the Memorial Sloan Kettering drug abacus, and Peter mentioned it earlier. For those of you who haven't looked at it, this is what it looks like in terms of the factors that go into deciding the price of each drug. So, dollars per life year, a discount for toxicity, a novelty multiplier, so mechanism of action is taken into account, as is cost of development. And a rarity multiplier and population burden of disease to take into account exactly how many patients might actually be impacted by this particular drug. And so this is what the tool looks like with all of their drugs integrated here. So for example, here I've highlighted nivolumab, where the actual price is $12,000, while the abacus price is less than half of that. Now I could change that by moving those levers up and down, depending on what I think is most important. So here the abacus predicts a price that is lower than the actual price of the drug. But based on these sort of just standard settings, the abacus price for dasatinib is actually double of the price of what the drug is right now. I think the benefit of this tool is that you can actually make changes based on what's important to you. But I think the downside, and really this applies to all of the three that I've talked about, and there are others that I haven't discussed today, is that none of these really get to value for patient. Right. None of these really describe how much a patient is going to pay for any of these particular interventions. And that's because it changes. It changes not just by patient to patient, but for each patient, month to month. And so it's extremely difficult to find a tool that could predict that cost, at least, for a patient. So what do? How do we actually understand what patients value? And how do we help them make a decision around value? Well, go back to the tried and true tool of communication. And that's where my responsibility as a provider lies. We did a study that actually just came out very recently in AJMC, where we asked patients whether they wanted to talk to their oncologists about their personal costs. And about half the patients we surveyed said they wanted to have a cost discussion with their oncologists. But interestingly, only 19% had the cost discussion. So we saw this disconnect between patients who wanted to talk about costs but actually had the cost discussion. So then we asked them why. Why didn't you talk to your doctor about costs? The vast majority said, well, it wasn't enough of a problem, but 28% said they wanted the best care regardless of cost. And this is really interesting to me, because in my mind, patients are linking cost to quality. And they're afraid that if they talk about costs and they say they can't afford this, they might get lesser quality care. And that's a really important point. 18% said it's not their doctor's job, or their doctor can't help. So then we looked at the very small proportion, that 19%, who said they did talk to their doctors about cost. And we asked them, after you had a cost discussion with your oncologist, did your out-of-pocket costs decrease? And actually, this should have been the question at the beginning of the talk. So just shout out, what proportion of patients said their costs decrease after a discussion? What percentage? Ideas? 50? 10%. 57%. So more than half said their costs were decreased after talking to their doctor. And a lot of people are surprised by this data. I was really surprised, because every time I talk, I'm an oncologist, I don't know how much the MRI is going to cost. When I talk to a room full of oncologists, they say the same thing. There's no way I will be able to help my patient. So the next question we asked is, when your costs were decreased, how were they decreased? 75% of the time, costs were decreased without changing treatment. This is particularly important in oncology, where we don't necessarily have alternatives. So what these oncologists were doing was not groundbreaking by any means. They were referring patients to financial assistance and advocating on behalf of the patient with the insurance company, the vast majority of the time, to decrease cost. So what we need to do is more of this, and we need to do it more efficiently. So when we talk about what patients value, I think it's clear that patients value these characteristics, but I guarantee you the weight of these characteristics changes. It changes by patient. It changes for each patient over time and based on where they are in their course of disease. So it's an important question to consider, but it's also important to realize that, as I said this morning, there are two separate discussions here, right? There's cost and value to society, there's cost and value to patient, and the challenge is to figure out where we can find the overlap. Thank you. We have a couple minutes for questions.
There's been a lot of talk about all of the value initiatives, the ASCO, the NCCN. Do you think that it's more of a nice to know, or do you think that they're actually going to be impactful for practices or payers or even patients in terms of treatment decisions?
Right, great question. So you asked, would it be impactful to practices and payers and treating physicians, right? So yes, maybe, probably not. And the reason I say that is because, yes, if practices and payers, sure, can understand how we're making, decisions. But for the treating physician, particularly when it comes to cost of care, there was nothing in any of those tools that tells me how much my patient is going to pay. And I would really love to see something like that. I think some payers have tools on their websites that can help in that regard, but they're not perfect, and not everybody has access to them. So I would say kinda is the short answer. Okay, thank you.